Just this past year, it was shown 75% of Americans don't support a database of private health in hands of federal government, and 56% want stricter laws from the government accessing healthcare records. In 2001, people still saw national health databases as an idea of the future, or even as far as 50 years away from occurring. Are Americans as well informed as they should be, or is their fear a result of propaganda? The main fear is a fear due to lack of privacy, which is a very understandable one. If a national medical database was implicated and data had to be shared between providers, standards would also be implicated. The sender would have to encode and communicate the record, and the recipient would have to decode, record, and verify the authenticity of the file, making it harder for hackers to gain access to these files in which names are not attached but IDs are given. Some say the proposal to encrypt personal identity numbers into pseudonyms was inadequate. Others say that if people want to find out information, they will find out the information. Is hacking the main issue? Consider the following. In the past, a Florida healthcare worker leaked a confidential list of AIDS patients to newspapers. A Colorado medical student sold medical records to malpractice lawyers. In November 2009, Health Net lost 1.5 million patient records but waited 6 months to disclose the incident. Not one patient, law enforcement agency, or government entity was notified of the loss for 6 months. The disk that was lost not only contained personal information about nearly 2 million patients, but also private information on at least 5,000 physicians. If our health record privacy is on the line anyway, we might as well reap the benefits from an electronic database. In 1996, HIPAA came to confront these issues of privacy. They stated their goals: make health insurance portable, reduce fraud, standardize health information for electronic processing, and provide privacy. These goals were set under the following standards: requirement of standardization of information such as transactions, claims, diseases, procedures, drugs, equipment, identifiers for providers, benefit coordination, and electronic medical records. Currently, standards are being implemented in stages. The Federal Register estimates electronic processing could save $1.5 billion a year. Looking deeper at the benefits of a medical database, it would facilitate an epidemiological surveillance and investigation. Medical organizations could better track disease outbreaks and respond to them. Currently, the process consists of labs required to report disease and telephone calls, along with written documentation by physicians. Among these diseases, only half of these STDs are reported, therefore cutting prevention, research, and education. Expanding on research, if procedure outcomes were documented in a national electronic database, it would result in a growing goldmine of information that could be used in many ways, including improvement of treatment success and attracting new patients to new improved surgeries that otherwise may have not existed. The closest thing this country has is used in every VA hospital across America. In order to sign on to the database in a VA, you will need 3 things: the Veterans Health Information Systems and Technology Architecture, a proxy server, and a client workstation. These checks and balances make it hard to access if unauthorized. Studies prove that such databanks provide more efficient, comfortable care. For example, in 1992, Fleming et al. Showed a national merged VA Medicare database is feasible and would enhance the validity and analysis of healthcare delivery for both the elderly, veterans, and Medicare populations. Further speaking about healthcare delivery, a nationwide system will provide a medical home, which is an approach in which each person has a primary care doctor who heads a team of professionals, perhaps including a physician's assistant, a nurse practitioner, a dietitian, a social worker, pharmacist, etc., to provide round-the-clock access to care. The family doctor helps patients get specialty care and through electronic records monitor treatments and inform specialists of these patients' progress. The medical home concept requires a new single payment system for both doctors and hospitals that give them incentive to. What it comes down to is a cost-benefit analysis. Let me paint you a quick scenario. You're on vacation and you get in a car accident and get knocked unconscious. You're losing so much blood that you need a transfusion and there isn't enough time for your blood type to be tested. Would you rather have a system where they could pull up your name and see your blood type, or would you rather have this information strictly protected, resulting in your demise due to the lack of blood type O?